Hi, Stephanie Glier. I'm here from the Pacific Business Group on Health. For those of you, and I have no disclosures. For those of you who do not know the Pacific Business Group on Health, we actually represent what Dr. Golden referred to as the awkward self-insured relationship. So PPGH is a nonprofit organization that for about 25 years has been leveraging the power of our members, who are mostly self-insured employers. We have about 65 members who collectively spend $40 billion a year purchasing healthcare services for 10 million Americans. And our mission as an organization is to improve the cost and quality of the system across the system, not just for our members. And we do that through initiatives in care redesign, in transparency, in payment reform, and in policy. One of those initiatives is the Consumer Purchaser Alliance, which is what I'm here representing today. The Consumer Purchaser Alliance is a joint coalition co-led by us in the National Partnership for Women and Families. And we represent the end users of healthcare, so those who receive and pay for healthcare, who are interested in getting better value out of the system. In a lot of cases, we focused on performance measurement and the information we need to ensure that we are getting more value. So what does that actually look like? This is actually very similar to what Helen had talked about. What patients think we need out of the system, what consumers and purchasers need out of the system, is value from the patient's perspective. We need to know that we're getting care that improves people's health, that maintains their health over time, compared to the total cost that goes into improving that health. So this quote is adapted from Michael Porter. This is not new, and this is not mine. This is not my idea, but I think this is a nice indication of where we want to be going. So thinking a little bit more practically, what do we want out of measurement of the system? We're not actually looking at how to shape the system as a whole. We're thinking about, as we engage with the system, what do we need, what kind of information do we need as patients? We need to know that we can get the care that we need that's going to maintain or improve our health. We need to know we can get it when we need it, and it's going to actually get us to achieve our goals. And to be sure that that is true, we need both information that enables practice improvement, that's going to drive the system in a way that gets us quality, but also selection is important. I think back to Brent's point, the two streams of getting to a better system are both important, and I think it's really important to ensure that consumers, patients, purchasers, regulators, policymakers, whoever else was in that list of that graphic, do have information to make informed choices. I think without information about selection, we're operating blind. You have patients who probably are choosing providers or facilities or plans or treatments that are delivering worse outcomes for them because they don't have enough information to make an informed decision. And relying on a trusted advisor alone is really operating in blind faith. So where is measurement failing us today? In particular, I think this top line issue is the most critical one. So the measures that we're working with, and a caveat here, all of these are very hyperbolic statements. None of them are absolute. We certainly have some measures that are important and very closely tied to things that patients care about in an immediate sense. If we're talking about mortality or surgical site infections, those are things that patients really want to know about. But in a lot of cases, the measures that we have available in the system are not the things that we care about as an individual patient. And part of that is because it's very difficult to measure the things that matter to us. How do we know in a systematic way whether, whether Helen's mother is going to be able to go to her bridge club? Maybe that's the thing that is important to her. Can we be sure that healthcare is enabling her to continue the quality of life that she wants? Related to that is that most of the measures we have now really do place an emphasis on meeting clinical guidelines. And those are important. Clinical guidelines are closely tied to evidence, but they really are a process measure, not looking at the outcomes. They're linked to outcomes, and they are likely to drive the outcomes that we want, but they are not telling us the information that we actually want. So for me as a patient, I don't need to know that you are following clinical guidelines, or I'd like to assume that you're following clinical guidelines when I go see you, but that seems very much like a floor. I should be able to assume that anybody I go see is probably following clinical guidelines. If you're not, yikes. But if you are following clinical guidelines, are you also putting in place the other pieces of care that are required to make sure that those are serving me as a patient and getting me the outcomes that I need? So the third piece of this, why it's so difficult to get to measures that are actually the outcomes that we care about, is that there are all of these tensions in the system about who's being measured, what incentives are tied to those, and what does that mean for the measurements themselves. So I think back to Brent's point about the aims defining the system, what are our aims? And are we driving all of our strategic improvement activities towards the same set of patient outcomes? Can we actually identify what the priorities are here so that we can take our individual quality improvement efforts and our selection efforts and make sure that they're driving in the same direction? I think to Helen's point, if we're measuring a nursing home in one way and a hospital in one way and a clinical practice in another way and a health system, health plan in a fourth way, it's almost impossible to see what that looks like from a patient's point of view, because you're going to end up with different levels of performance and different, if the data feeds into different ways, then you're going to end up with a different total outcome, which leads back to 30% of hospitals being reflected as the top 2% of performers. So how do we hold people accountable? What is reasonable to expect out of clinical practice? Is it reasonable to say, okay, you're my primary care doc, my goal is to go to Bridge Club if I'm Helen's mother. Sorry, Helen, I don't know if your mom plays bridge, but learn bridge. Is it reasonable to say, hey, primary care doc, I would like to learn bridge. Can you make sure that I'm able to, get on the bus myself or stay walking this long or whatever the actual functional status is? Is it in that clinician's control? Do they have a reasonable expectation to be able to improve care in a way that actually serves the patient's goals? I think there's a big tension there in the measurement science in terms of how we structure the measures, but I also think it's very important for us not to get too caught up in what is reasonable to expect an individual clinician or an individual team or a system of care to provide, and to say, these are the things we care about. These are our priorities, and we're going to figure out how to push that down the line. Oh. Thanks for offering us the directions to our better measurement system. I think it really is important for us to be clear about what our priorities are. So I'm going to sort of skip through the rest of this. I think this is pretty straightforward for everybody here. The information we have available is not timely, especially when we're looking at claims data. The feedback cycle is so long and so removed from clinical care that we can't really use it for measurement or for quality improvement or for selection. And so it's not serving most of our main needs as well as we would like it to. So just to take a step back again, what is it that we want these measures to look like? I'm again channeling Michael Porter here, so bear with me. This is a quick tiered hierarchy of what matters to patients. If we're looking at patient outcomes, what does that mean? So first is a point in time, what kind of health status is possible to achieve or maintain? Can we actually get people, A, to survive, and then B, to be healthy and be well? The second tier here is what the process looked like to get to that point in time. How long did it take them to recover? How long did it take them to return to normal activities or to achieve a care goal? And in addition, during that process, were there negative impacts? Did they experience ineffective care? Did they have unintended consequences or adverse impact? Did they face complications? The third piece here is really a sort of forward-looking piece. How long-term can this health status be retained? Do they have a recurrence of illness? Do they have recovery from injury and then have a functional status decline after that? And I think if we actually take this a little bit more broadly, you can also build in the patient experience into the big picture of the health outcomes here. So during the process of care, did people feel treated with respect? Did they experience communication breakdowns? Did they experience poorly coordinated care? And then if we look at the other pieces that also matter to patients, we're thinking about the total cost of care as well as their personal out-of-pocket costs. We're looking at whether they had meaningful choice and access to the care that they needed when they needed it. And more broadly, we're not just looking at individual patient outcomes. We're looking at whether populations are being served well, whether populations as a whole are achieving health, and whether the care systems that we're building and the measurement systems that we're building have any unintended consequences on either widening the gaps that we have in care now or continuing to not serve underserved populations. So how do we get there? This is a very lofty set of statements, and from the consumer point of view, I think it is often difficult for us to feel like we can engage in the nitty-gritty of how we do the improvement activities. I think we are trying to stay more at the priority level. So thinking more directly, what do we do next? If you want to have more outcomes that are relevant to patients, you need to get more information from patients. We need to have measures that are based on patient-generated information, including patient-reported outcome measures. And there are a bunch of initiatives going on now that show a lot of promise in being able to use PROMs for clinical improvement and for accountability. For example, in Massachusetts, the Alternative Quality Contract has been able to improve or to use PROMs on a 3 to 5 year cycle where you start with implementing it into the clinical workflow, and then when that is fairly effective, moving it into a population level where you can start using it for shared decision making. And then at the end, once we have really incorporated it into the culture of practice, actually being able to pay based on the performance on the results of the PROMs. Excuse me. Second, there is a major initiative going on to use more standardized measure sets for conditions that represent substantial disease burden, including PROMs. So the International Consortium on Health Outcomes Measurement, ICHOM, has been doing this internationally for quite a long time, and we're starting to explore working with them more closely in the US to look at these major disease burden areas and take care of or look at building a standardized set of measures. So it's not quite identical to the various core measure set initiatives going on right now, but it is a similar concept where you start with a sort of comprehensive package that says, okay, for this condition, for a patient who's experiencing this condition, what's the total package that we care about for him? So again, back to what Dr. Golden talked about, if we're holding providers accountable for a basket of measures, or if we're holding a system accountable for a basket of measures to care for patients with a particular condition, having a standardized set that includes patient-reported outcome measures can make a huge difference in the total structure of care to support a patient through that journey. Third, again, if we're trying to get patient outcomes more central here in our measurement system, we need to make sure that consumers are participating at all levels. So having more consumer engagement at the clinical encounter level, through shared decision making, through other types of engagement, ensuring that consumer input is a major facet in the way that organizations are structuring their own improvement activities to make sure that the way that you're improving care does actually meet consumers' needs, your own patients' needs. And also at the policy level to make sure that our state, regional, national focus is also serving those patient needs. And I think through all of those, we can revisit the way that our current measurement enterprise is structured to help us recenter on those patient outcomes that we care about to get back to patient value. Thanks.